Hi, everyone. Thank you so much for coming to today's Medical Student Grand Rounds. We are so excited to have Shane Scott presenting this early afternoon. Before we get started, I just wanted to quickly overview what Medical Student Grand Rounds is for any people who might be new to attending this speaker series. So if we could go to the next slide. Shane, thank you. So Medical Student Grand Rounds was created last fall, and it was created to acknowledge medical student achievements and passion. So the format that we've established for MSGR is that it will have a medical student presenter, such as Shane today, introduced by a faculty mentor. Currently, we are holding MSGR on the first and third Tuesday of each month at 12 p.m. and we'll be going through the end of April. We'll be using Zoom through the end of April, and we'll reconsider it in the fall if we want to move back to in person. You can view the schedule for the rest of the year at go.osc.edu/MSGR. And if you're really inspired by Shane's talk today and want to nominate someone to give a talk on his or her own accomplishments and passions for the fall year, you can go to the link provided to nominate a medical student potential presenter. And finally, if you would like to view Shane's talk again or look at previous MSGR talks, you can go to our YouTube to view all of the previous MSGR talks that were given. So without further ado, next slide, please. I will virtually introduce Shane's faculty mentor, Dr. Abigail Norris Turner, who is an infectious diseases epidemiologist here at The Ohio State University. She was not able to attend in person, but has recorded a very thoughtful, kind introduction for Shane, which we will present now.
My name is Abby Norris Turner, and I'm a professor of internal medicine here at Ohio State in the College of Medicine. It's my profound pleasure to introduce today's Medical Grand Rounds speaker, Shane Scott, who will speak about his great passion, Manikins for All Skins. Shane is a third-year MD PhD student whom I've known since the fall of 2019, when he enrolled as an M1 in the Advanced Competency elective that I taught for first and second year medical students. That course is called DELTA, which stands for Developing and Empowering Leaders Through Advocacy. Over 2 semesters, we learn about social determinants of health, and we discuss approaches through which future physicians can become leaders in addressing those factors with their patients, in their institutions, and in their communities. While DELTA is about development of these skills, some students arrive already possessing incredible strengths in both leadership and advocacy, and Shane is a prime example of this. His passion about creating and promoting institutional efforts in diversity, equity, and inclusion efforts broadly, and particularly in simulation mannequins, predates his arrival at OSU, and he spoke about it frequently while a student in Delta. He's worked with partners in the college and elsewhere over the past couple of years to implement his vision. He believes, and will provide evidence in his talk today, that trainees who practice clinical skills using mannequins with diverse skin tones emerge as more skilled, more confident, and more capable medical providers to patients from racial, ethnic, cultural, gender, and other identity backgrounds different from their own. But Shane's fuller vision, which he will also address today, is that Manikins for All Skins and other initiatives led by students provide institutions the opportunity to meet 3 objectives. First, to center, honor, and recognize student thought leaders. Second, to provide pathways for leadership development. And third, to introduce avenues for both research and advocacy. Without further ado, I now turn the floor over to Shane. My name is Abby Norris.
Thank you, Abby. Good afternoon, everyone. My name is Shane Scott, and I'm a third-year MD PhD student here at the Ohio State College of Medicine. Along my journey to discover my place in medicine as a medical student, I have learned a great deal about the current state of medical education. Today, I'm going to focus on one aspect of medical education, which is simulation training, where I believe this is one example of structural inequities present in our profession today. I believe the Manikins for All Skins campaign, which seeks to catalyze the increase of Black and brown bodies in simulation training, can lead to meaningful improvements in this landscape. Today, I'm excited for this space our Medical Grand Rounds team has afforded me to talk about this initiative, and I hope to meet several goals. First, I want us to reimagine medical simulation with mannequins for all skins. Second, I would like you all to continue this national dialogue at your respective institutions. And lastly, for medical administrators, I hope that my journey serves as a model for appropriately centering and empowering Black and Brown students doing advocacy work. Now, before I begin my talk, however, I have a few disclosures to make about the complexity of this work. Now, while my talk seeks to address some of the past uses of Black and Brown bodies in medical simulation, it is not complete. It also does not account for and does not address the fact that culture and race are separate but modifiable constructs. It does not address gender biases in medical simulation and simulation mannequins. Another special component of medical simulation, which involves the use of standardized patients, also lacks representations of Black, Brown, gender nonconforming, as well as patients with disability. I say, if you're in the audience and you are moved by the lack of diversity in these other aspects of medical simulation, I see you. With these disclosures out of the way, let us get into this presentation. So in this talk, I'll address my why, using the lens of the famous doll test studies, because I still get questions about why does it matter to you, Shane? Second, I will ask us all to recall historical accounts of Black and Brown bodies in medical simulation of the past. For I believe, without revisiting the past, we cannot understand the origins of medical simulation. And like anything else in our society, knowledge of the past is critical for us to address structural inequities that remain today. I will then give us a glimpse of how Black and Brown bodies are now minoritized in medical simulation and the implications of this minoritization. After this, I'll take you through a journey where I went to effect change at my own institution and detail some of the lessons that I've learned. So while this talk focuses on my personal experiences, which have afforded me to illuminate and seek ways to address inequity in medical simulation, it is easy for me to say, well, I want to address this gap to reduce implicit bias in healthcare, to create a training environment that is more representative of our diverse student population towards improving patient safety. But even though we can all agree that reducing bias in healthcare is essential, some people will still ask me, why does it matter if simulation mannequins look like you? Well, that answer to that question allows me to look backwards at the 1940s study, a doll test study by Doctors Kenneth and Mamie Clark. In this study, they conducted a series of experiments now called the doll test, trying to assess the effects of segregation on African-American children. The researchers used 4 dolls, which were identical in concept and which were identical except for color, to test children's racial perception. The study also had children between the ages of 3 to 7. And when they were asked, which doll do you identify as and which color do they prefer, a majority of the children preferred white dolls and assigned positive characteristics to it. I believe this study highlights the impact of holding whiteness as the gold standard in our country. And we can also ask the question, holding whiteness as a standard for medical simulation is also the current standard. And what are the implications of that for our trainees? Well, many of you will say, well, this study is from 1947. So I asked, do we still have evidence that holding whiteness as a gold standard have effects on children today? And indeed, when I look in 2019, the Bird and colleagues revisited the doll study. And here, while a majority of the students, the children, were African American, they all ended up choosing lighter skin tone dolls when asked which doll looked more like them, even when they were of darker skin. They also preferred straight hair. But what was interesting to me is that when asked about which doll is mean, 54% of children perceive the darker doll to be mean when compared to white dolls with dark hair, white dolls with blonde hair, and lighter skin tone dolls. This data is staunchly similar to the 1947 Clark dolls test. And again, I conclude that images matter, representations matter, and the stories our world portrays about Blackness does matter. More importantly, in medical education, the absence or lack thereof of Black and brown mannequins sends a message to Black and brown physicians beyond patient safety. So now that we have that out of the way, you say, okay, Shane, these are a bunch of studies. What does it mean to you? Well, for me, these studies have allowed me to contextualize, why is it important for my goddaughter to own dolls that look like her? The goal is for her to see and love images of herself and hold herself and people who look like her in positive regard. The same concepts has allowed me to contextualize why I want to add simulation mannequins representing Black and brown folk and all the shades in between. First, I want to normalize Blackness in formative medical education. Second, I want to practice intubations, venipuncture, intramuscular injections, and simulate on mannequins that are Black, brown, white, and all shades in between. Because I believe these experiences will bring me comfort and closer to the real populations of people that I serve. Beyond this, I have a responsibility to myself to ensure that I'm the main character in my story, creating the diverse, representative world I want to exist in. So now that I've contextualized my why, let us revisit the history of Black bodies in medical simulation. Modern medical simulation, as we know it, was developed for many reasons. One was to increase the education and training. It was to reduce accidents in medicine, and also to increase the access to procedural training with the goal of getting as real as you can to patients. So I contend that if we're trying to get as real as we can to patients, then medical simulation should include Black representation. Well, throughout our history, we've seen that medical simulation has taken several forms. One of them is that it dates back to the non-consented exploitation of Black bodies in the transatlantic bondage. And what did that look like? Well, daguerreotype images, which are the first types of commercial photography process that allowed Americans to preserve their memories and their history, allowed us to see how images of Black people were generated, and these in the 1950s, and used to emphasize physiological features of Black bodies as evidence that Black bodies differed from whites. It's important to me to humanize the individuals that are in these images. So to your left, we have Renti from Congo. And in the middle, we have Jack from the Guinea coast. And lastly, we have an unidentified man. So you say, okay, well, is this it? The answer is no. Clinical display was another mechanism by which Black and brown bodies were used in medical simulation. In this case, Black patients were subjected to observation, inspection, and questioning because physicians were fascinated by unusual bodies and disease phenotypes. But it doesn't end here. Medical experimentation is also under the umbrella of medical simulation. And in this presentation, I would like to highlight the history of Dr. J. Marion Sims, who's dubbed the father of gynecology and credited with the invention of the vaginal speculum. He performed surgical techniques without anesthesia on Black women. Now you may say, this is the old study, Shane, but there are consequences of this narrative. One of those consequences is that Black women are seen by our medical providers as stronger, with higher pain tolerance. This consequence is speculated to underlie the increased neglect of Black female patients who seek care and when they complain of pain. And the most important modern day example is here of Dr. Susan B. Moore, who died due to COVID-19 complications. She had to complain about her excruciating pain and no one would listen. A study coming from that hospital afterwards stated that while there was no neglect in the care that was provided, they did agree that there were some implicit biases in the healthcare team that treated her. Now we all know of the Tuskegee untreated syphilis study, where Black male, about 600 of them from Alabama, between the ages of 25 and 60, went untreated for syphilis. These men went home and transmitted this disease to their female counterparts, even though there was a cure at the time. What did we learn from this? Is that Black males and females were disposable. Now, those are tangible examples. But another one that is harder for us to see is the story of Henrietta Lacks, a Black woman who was diagnosed and unsuccessfully treated with cervical cancer in 1951. Doctors preserved a sample of her tissues without her consent, and 70 years later, her cells were immortalized for the purpose of medical training. And what did we learn from that? She was a woman reduced to cells. So despite these early non-consented contributions of Black and brown bodies to medical simulation, what has happened? Well, recent technological advances and legal protections for Black and brown individuals have made it so that white dolls or mannequins have now replaced Black bodies and other indigenous people as the new form of clinical display for medical and surgical demonstrations. Now you may say, Shane, what is the evidence for this for the researchers in the room? Well, in a descriptive study published in 2017, researchers examined racial diversity of mannequins offered in brochures and catalog distributed at a simulation conference in the United States. When they looked at the number of body parts, which were 2,035, and full body mannequins, 395 that were advertised, they observed that 94% of those mannequins were white or peach colored, while only 6% was Black. And this is astonishing because this is a disproportionate representation of the US population, as well as our patient population. At the time, the authors recommended that medical institutions should enact policy to require diversity as a standard to compel manufacturers and educators to provide a more inclusive environment. But again, this study was 2017, and I needed an assessment closer to today. So in another study by the same group, published in 2020, the researchers looked at racial diversity in simulation centers globally. The results were the same. Racial diversity in medical simulation is inadequate when you're looking at mannequins, when you're looking at body parts or task screeners, when you're looking at standardized patients or simulation facilitators. The author's conclusions are in alignment with this talk. It was that international and domestic simulation standards should change towards increasing racial diversity in all aspects of training. Now, what are the lessons that we can learn from this minoritization of Black and brown bodies in medicine? Well, the past misuse and mistreatment of Black and brown bodies in medicine is a truth and cannot be debated. But now we have a chance to move forward from the structural racism of the past. One of the many paths forward is to incorporate mannequins of Black and brown representation in medical simulation. The other is to include Black and brown individuals in medical simulation. Now, armed with the knowledge of our past, as well as the present, I believe this is evidence for the call for diversity in simulation. And I believe we can now walk in my journey to make Manikins for All Skins a reality from its inception to progress here at The Ohio State College of Medicine. But before I begin, I want you to close your eyes and create a vignette in your mind that describes the persons that compelled you to seek a profession that would allow you to be in the business of taking care of the human family. For some of you, these situations involve many people. For others, it may be one person. For me, it's my grandmother, my mother's, my father's, and all the people in my little town of Recabessa St. Mary who believed in me and believed I was their doctor way before I realized it. Now, as we journey on this together, hold that person and persons in your mind and imagine you've arrived in medical school, no longer a spectator, but a participant in medicine. Yet the essential features of these people are absent in your classroom, in your texts, and in your medical simulations. How would you feel? What would you do? How do you create for these people, reimagining them in the current walls of medicine? With those questions in mind, let's go ahead. So in November 2018 to March 2019, I received acceptances to several medical schools across the country. However, I was conflicted about whether I would undertake a dual MD PhD or an MD PhD only path. And with that confusion, I decided, hey, let's go to our medical school second look sessions, because they would afford many things. I will get to meet prospective classmates, future colleagues, and also get a deeper glimpse of what a day-to-day life in a medical student is at each institution. The highlight of every session was the opportunity to participate in medical simulation. And several schools had introductory sessions that allowed us to practice intubations. But when I arrived in these spaces, I realized none of the mannequins used represented Black and brown bodies. I got the courage to ask the facilitator at one school, and they uncomfortably stated, I don't know, but I'm confident there is a Black baby mannequin though. In the end, I decided to attend the Ohio State College of Medicine because there were amazing trailblazers like Dr. Quinn Capers and Dal Gray doing amazing work to dismantle gaps in inequity. So once I matriculated in May, I spent parts of my summer reaching out to medical students who I met during second look, asking them, hey, what does the mannequins look like at your school? Through those conversations, I recorded some telling quotes. One of them, paraphrased here, I was encouraged to use the white mannequins to practice venipuncture because it is easier to see veins on. Another said, I used my first Black mannequin in my 4th year during ACLS training. Another that was equally important is that someone stated, my first time doing venipuncture on a Black man who was also overweight was during clinic. I felt bad having to stick in multiple times. These stories were important to me. So now I started to look, do any of these quotes have any truth to them? So first, I looked in the literature and I found, indeed, one study has shown that infants, African Americans, and people of Asian ethnicity, and those who are obese, are associated with decreased vein visibility with the naked eye. In fact, this study went on to look at infrared vein finding technology to increase IV placements. But do I believe infrared vein technology is the key to increasing the use of Black and brown mannequins in medical simulation? No. But if instructors do believe that this is a problem and they can't use current Black mannequins for venipuncture, then it is their responsibility to inform manufacturers to create diverse products that are more effective for treatment, for teaching this technique. I must point out, however, that every phlebotomist that I have engaged with tell me that the correct venipuncture technique requires locating a vein by palpitation, which is usually by touch or feel, by pushing down in the skin with your index finger, not by seeing. So I'm confident that the excuse that it's better to see the veins on white mannequins is not really valid for the right teaching technique for venipuncture. But I was also curious, what could some of these implications that I'm learning about have on modern medicine, right? What I found was shocking. In the 21st century, medical students, residents, nurses, and registered nurses continue to endorse false narratives that Black people feel less pain and have thicker skins. So I ask myself, is this because we hold white as a standard in medical simulation? Maybe. And the other thing is, in my field, African Americans are given more blood transfusions perioperatively for certain surgeries like coronary artery bypass and total hip replacements, despite the association of blood transfusions with increased mortality and complications in these patients. So taken together, and all that I learned, I realized there are implications for understanding race-related biases in healthcare. And most importantly, they can affect patient safety. So with this, I felt compelled that I could demand change. I had a case for change. And that change was towards patient safety. So in order to do this work, I was informed that the most effective way to do this is to become a student council representative, specifically a class president. which will allow me access to pitch my initiative to our deans. So with the help of student council members that summer, I was able to effectively run and campaign for president. I wrote a compelling speech, of which is an expert. I also made flyers. And I want to point out that in my flyer, you see mannequins for skins. Again, this was the development process. We were learning here. But I was nervous, right? Giving out these flyers. But at the time, it wasn't hard to convince students my story was true. By then, we had all practiced venipuncture and intramuscular injections on white or peach colored mannequins and body parts. At the end, I became co-president and I had access to our deans, but I was reticent about sharing my ideas with them. In some ways, you could say I was intimidated. So from late 2019 to early 2020, I became more of a listener and an observer. I wanted to know how other students were engaging with deans and faculty, and what was the most effective way to communicate this need for change. I went ahead and refined my call to action speech through my course, to my Delta course with Dr. Norris. I was a nervous wreck for that speech, but my work shocked the conscience of my colleagues, who I regarded at the time to be more confident and more woke than me. Their reception of my speech, as well as their comments about their experiences in medical simulation, made me realize that Manikins for All Skins initiative was necessary. So in January of 2020, I got the courage to speak to the deans and was given contact to our clinical skills center. In my conversation with the clinical skills team, they welcomed my initiative and ideas with broader goals to increase representation of female mannequins, as well as improving the realism in medical simulation. In March 2020, I felt, yeah, man, all this is working in the right direction. I was offered and invited to engage with live cast body simulation vendors to demo several of their mannequins. However, while these mannequins, as you can see, are incredibly more realistic, they lack the functionality we needed for most simulation exercises, meaning we weren't able to do intubations on them and we weren't able to do things like ultrasounds, but things were looking great, you would say. This is March 2020, so you guys know what happened, right? Our enemy of social contact arrived, COVID-19 pandemic, which halted our efforts at the clinical center. But this didn't interrupt, while this interrupted my continued conversations with leadership and simulation mannequins, I continued this conversation in other spaces. And I love Zoom, because Zoom created a deeper connection than we once had with other students at other medical institutions. So I was able to show up at happy hours and ask about, Manikins for All Skins at their institution. In addition, in October of 2020, I, along with four other OSU MSCP students and a program director, launched the organization, the American Association of Black Physician Scientists, which also provided me avenues to talk to current and aspiring medical students across the country about what are some of the implications of this absence of Black and brown bodies in medical simulation. Later, our OSU MSCP program allowed me to give a version of this talk as a TED session. From that talk, I was recommended to give this medical student grand rounds to you guys. Now you say, you've done so much talking, Shane. You've done so much community building and getting a lot of buy-in on this idea. What happens next? Well, in February of 2022, OSU.com announces the acquisition of diverse simulation mannequins. Now I was excited, and my colleagues had a spectrum of congratulatory messages ranging from, congrats, man, I see your initiative finally coming into fruition, to the more visceral responses like, I intubated on a Black mannequin today and thought of you, haha. It sounds creepy, but you get it. And indeed, I did get it. Representation matters. And this student was excited to practice on a Black mannequin for the first time. I am grateful for the progress we've made, but there's still work to be done. Some of the steps that I believe that we can do forward is that we need to reimagine representation of Black and brown bodies in medical simulation as we know it today at our own institutions. And more importantly, let's reimagine them with the dignity and humanity they deserve. Furthermore, Manikins for All Skins is not only a concept for me, it is also my person, it is my grandmother, it is my mother, and all the elders that nurtured me in my early years in Jamaica. And my journey to find my place, advocating for diverse mannequins, has been hard at times. It has never been easy to challenge people to recognize the systemic medical racism of the past in such a visceral and visible way. But I believe that diverse mannequins are one way to begin to reverse the erasure of the past. And I challenge all of you to work with me and your institutions to continue to create spaces that demand the use of racially diverse mannequins that represent the spectrum of potential of our diverse patient population. In addition, these efforts, though only minute aspect of our training, can change how physicians approach difference in medicine. In fact, I believe success in creating diverse simulation training can open doors to addressing ways to improve physician interactions with other populations, including transgender individuals and patients with disabilities, to name a few, towards preparing the next generation of healthcare professionals and improve patient safety overall. But I wouldn't give all this talk and tell you about my journey without giving you guys some lessons learned from this process. First, I believe that my unwavering passion, personal connection, and personal investment in this initiative was the most invaluable. It provided a concrete humanistic example of how current learners are being impacted by the absence of mannequins that look like them and the patient populations they hope to serve. It also helped me to leverage a great deal of support on this issue. Second, I believe it was really beneficial for me to engage initially with the negotiations with live cast simulation vendors. However, due to the pandemic, I was not able to be a part of the later negotiations to secure our current mannequins. In hindsight, that opportunity would have allowed me to better understanding the manufacturing side of mannequins. Because as the research shows, 90% of the mannequins that are marketed in catalogs are white. I think my involvement during this process would have allowed me to provide manufacturers with a tangible example of the impact that the absence of Black and brown mannequins have on our current learners. Additionally, my success thus far with this initiative has also allowed me to recognize how institutions can leverage the diversity of their student body and help them develop their skills as leaders committed to pushing awareness and change in the communities. In brief, I think institutions should empower student leaders with spaces to voice their ideas for change and tools, importantly, tools to enact these changes. They should also consider using the apprenticeship model of training, where faculty members use their status and positions to help students push their initiatives. Thank you, Dr. Norris. We should also create a model for institution-student partnership, one that centers student-led work. But most importantly, I believe we should check in with students, leaders doing this incredible work, because this work is hard and the labor, though necessary, can be taxing. So without further ado, I think that my story, as well as the revisits of our past and those implications that holding white standards has on medical simulation, as well as life outside of medicine, is enough reason for us to change and push for mannequins for all skins. Thank you. So, so one last thing, you all know me, gratitude is a must. So I want to thank my family, including my mom, my grandma, all my family and friends who are extended in the audience, as well as all the doctors here. The Smith Lab, shout out to you guys for helping me calm my nerves and making me feel that I am the expert to have this conversation. To my OSU MSCP cohort, thank you from the genesis of all of this for being so open and honest with your experiences. My Delta cohort for pushing me to be the speaker and to push for this change that I need to, and to current and past medical students at other institutions that were invaluable and shared their stories. Thank you.
Thank you, Shane, for a wonderful talk and for allowing me to be part of the dialogue. So for those of you that don't know me, I'm Dr. Jennifer McAllister, and I'm the Associate Dean for Education here in the College of Medicine. And since Dr. Norris couldn't be here, I was given the privilege to be part of the conversation today and to help facilitate the discussion and hopefully help to open a dialogue and allow us to engage in some conversation here with student Dr. Scott. So what I'd like to ask you all to do, if you have questions, please put them in the Q&A portion of the Zoom webinar, and I'll be happy to facilitate those. I guess, Shane, if you'll allow me the honor to ask you the first question, I'd like to start with a question to sort of follow up with the call to action that you closed with to leadership and faculty, and you proposed the framework for a model for us to go forward and to partner with students. And I'd like to ask you to build upon that, and to, if there's the single most important thing that we as faculty or leaders can do to empower students and to give them, the space to advocate as we work to build trust and partner. What is that single most important thing we can do as we work to build the infrastructure that you envision?
That's an excellent question. In my experience, and I can only speak from my own experience, I believe that having faculty support, having the spaces to candidly share what I believe is a necessary and important project for change were two of the most important things. Additionally, I think the tools to enact those changes were very important. I think at the end of my situation, I wasn't able to do as much as I want and be given those tools because of the pandemic. But I think just centering us and our voices and making sure that we're in rooms when there's dialogue being had about changes that affect us and affect our learning landscape is necessary and important. As well as, like I said, checking in on us and making sure that we know that you guys actually believe in the vision is super important for our own psyche.
Thank you for that. Do we have any questions from the audience? Seeing a lot of comments, just thanking you for your very powerful and impactful work. I guess while folks are contemplating and processing if they have specific questions for you, I think the other follow-up question I would ask for you, you mentioned sort of helping faculty and helping us to create that space and checking in with students. What advice do you have for your peers as they sort of begin navigating those conversations? Because you were, very candid and honest in your presentation about sort of finding the courage and sort of the space to engage with leadership, and especially in an area such as this, which can be difficult. And, we stumble, we make blunders, and it's the burden of having these difficult conversations and advocating for something that's very important to you. I mean, that all builds and it accumulates. And so what advice do you have for your colleagues and other student leaders who may have similar visions and things that are equally difficult and challenging? How would you empower them or encourage them to start taking those first steps?
Well, I think, like we discussed, I think accessibility to, like-minded faculty members whom you believe, will at least say, hey, I'll be open to listening to that idea and critique it in a way that is positive and forward-moving is very important. So, find that faculty member that is accessible to you and you feel comfortable sharing your ideas. And from there, ask them to be partners in your work. How could they use their status or their positions to get you to the right connections? Whether it was you, getting me to Dr. Files in the clinical center, and those are all necessary and important for me. And also you using your platform here as well is also a good support for the work that I'm doing.
So we've had a couple of questions come in, so I'll take them in the order that I've received them. So the first one is related to sort of opportunity for academic diversity of thought, and have you seen that, and how does that build with interdisciplinary collaborations, and what are your thoughts in that space? And sort of maybe opportunities and areas for growth.
So yeah, I think that area definitely needs a lot of work, right? I think our current understanding of diversity and inclusion work usually centers the people who this impacts and say, hey, can you tell me how we can change this? But again, like I said, this is very taxing work and we need partnerships. Because at times, as students, at least from my perspective, we know something is wrong, right? And as you guys saw, I went through an entire, months, and what you guys don't see is the literature and the reading and the constant conversation to really know that, to be confident that this is something that is worth pursuing. So I think once we move away from, centering the people who are being affected from leading these changes, and we start, having like true partnerships with them. And again, what that looks like is up for debate, and I have some thoughts on that. But I think that is the most important thing. If we move away from centering them and then work for student-led partnerships, then we can do a better job in the current landscape.
Then a follow-up question to that is, you mentioned the importance of an apprenticeship model, and why do you believe that that is important in your ability to create this type of change?
Because you're going to meet people who are resistant to change, and you need, people who who have experience and kind of sort of, helping you tackle how to respond to that resistance, right? Whether it's making your presentation, palatable to a wider audience, and, instead of using language that is more inflammatory, you want to be more open to invite a lot of people in order to make that level of change that you seek to make. So I think for me, that having faculty like mentorship was super important in that aspect, because again, like when we identify these things, they're visceral to us and they're so visible. And it's not that for a lot of people because for many reasons, but having faculty for me allowed me to, fine tune my story and, shoot through the gaps that I did get, and whatever opening I did get, I used it.
So I'm going to read this comment verbatim because I want to make sure that I'm addressing all the very important points in this question. So it says, simulations on mannequins can often be very traumatic events that have a long, painful history in the Black community. You mentioned the work of Dr. Sims. How do you suggest we use these diverse mannequins for simulations and education while also being respectful of the history of exploitation of Black bodies in medical education?
That's a perfect question. That is near and dear to my heart. So as I said in my talk, it's not as important for us to reimagine and Black and brown bodies within medical simulation for its importance of again for patient safety, or again for Black and brown students to be able to see themselves and see their family members, et cetera, and patients they hope to serve. I think that we should also reimagine Black and brown people with the dignity and humanity they deserve. So a lot of you are familiar, if you're a medical student, that there are stories that go along with some of our mannequin presentations. And those stories too should be orchestrated in a way that represents these beautiful and wonderful people as they are. And indeed, a component of that can be, for instance, if you're in your gyne-onc class, et cetera, one of the tools to remind students that, hey, there's a history here where Black females were like experimented on and without anesthesia, like we must hold space for that and some credence for that some people may not be open to. Let's jump into OMG, let's get to simulation with on Black bodies, right? Because it's still sensitive. But I also believe that there's some utility in that, and us seeing mannequins and body parts that look like us. It's also important for our patients. And a friend of mine, whom when I told about this talk, she said, man, Shane, how important it was for me to, be with my midwife, and like, they had a birth mannequin that looked like me. It was so good. I was like, OMG. And I was like, that's so awesome. Right. So I know the impact that can have. I also know the impact that our history has, but I want us to reimagine what we think about and for inclusion purposes of Black and brown bodies.
Thank you for that very thoughtful response. Another question that has come in is sort of talking about more global initiatives to address implicit biases and racism in medical education more broadly, and this being a very important step, but it's one piece of a very big pie. And do you have other suggestions for things that we as educators should be considering in addition to this important initiative to continue to tackle systemic racism and biases in education, and other what other blind spots or other areas should we be considering? You certainly mentioned other populations and other groups of learners and other members of our communities that we should be considering as we work to diversify our standardized patient population, et cetera. But are there other areas that you haven't had a chance to mention that you think we should be considering?
Well, I think there's a national dialogue about incorporating Black and brown bodies and Black and brown representation also in our textbooks, right? In our representation in dermatology. So that is also a landscape that we need to address and change. Yeah. Those are some of the things I have right off the top of my head. Still a little bit nervous, so.
You're doing a fantastic job. I'm gonna just scan the comments here because we've had a couple of come in the comments as well. So here's a comment that you may not have had a chance to read yet, that lots of folks continuing to just really recognize the great work that you've done. Do you think that having mannequins of different skin tones is enough to push a lot of the change in how physicians treat patients of color? Or do you envision that other specific actions will need to be taken in conjunction with bringing in diverse mannequins?
Oh, it's a start. It is in no way the like broader solution, but I think that having mannequin for all skins within medical simulation and like a mandate for instance, if we're having a session on intubations and we're having second look, like half the mannequins in that room, right, or whatever the amount of mannequins you have. If you only have 4 black mannequins and you have 30 others, like those 4 should be in that room, right? And so I think once we've done that part and gotten the mannequins in, then we need to start thinking about what the research says. And that's another aspect of something that I'm interested in trying to understand. Okay, then how do we get, the value out of these mannequins, right? Black and brown mannequins, how do we tell the story of not only of the history, but like what we can change moving forward? So I think as far as like the venipuncture situation, where currently some of the mannequins of students are saying that you can't really see the veins really good on, but that is an opportunity for us to talk about the use of better techniques for venipuncture, including feeling it. So I think that a lot of these things we'll get to learn better from all of these mannequins is what I'm trying to say. And based on the comments I've gotten, we're not really learning really good venipuncture technique because we're looking to see the vein instead of palpating to see the vein, which is what most phlebotomists do.
How can other students get involved in this initiative with you and continue to, or partner with you and to continue to advance this here within the College of Medicine locally and nationally? Because you've been involved in such an important conversation for the past several years, in many spaces.
Well, one, I think as in the goal that I stated here is, continue this national dialogue and use the hashtag mannequins for all skins, but also, when you're in spaces and you don't see representation, whether it's of mannequins, et cetera, you say, hey, I think it's important. You speak up, right? A lot of us see things, but we don't have the courage to speak up. I think this journey is an example that, speak up, do expect that you can get some pushback, but it'll get out there. And once it's out there, then, they'll have the opportunity what to do with it. And maybe sometimes you'll just have to do something about it.
Do you have any other last closing questions for student Dr. Scott? No? Well, thank you again, Shane, for allowing me to be part of this today and for your leadership in this space. It has been pivotal and it's been just inspirational. So I really want to thank you for that. And then there's the feedback form in the chat for those of you that would be willing to take the time. I know that we would appreciate that. And then I don't know, Allison, do you have any last minute comments you want to make?
Thank you so much, Shane, for your incredible talk, and Dr. McAllister for moderating. Again, yes, if you guys have any feedback for Shane, please fill out the Google form I just put in the chat. And his talk will be uploaded to YouTube within 48 hours, so you can share and disseminate the recording to all of your friends and colleagues as well. Amazing. So I will go ahead and end the recording, and I can then end the call.